Well, welcome to the Spondylitis Association of America's Spondylitis Educational Seminar. My name is Richard Howard. I'll be in addition to welcoming you, I'll be introducing the various speakers we have today. I'm the Associate Director of the Spondylitis Association of America, otherwise referred to as SAA. But I've also been a paid member of the association shortly after my AS diagnosis in 1989. I want to say hello to our live stream attendees. Welcome to Southern California. It's sunny here. It's beautiful here. Thank you to our medical professionals and researchers who have devoted their careers to spondyloarthritis. In particular, I want to thank our three speakers today, Dr. Hallegua, Sturdy McKee, and Dr. Lee. I want to thank this program was sponsored by two corporations, Amgen and AbbVie. I want to thank them for sponsoring us. And then we have two of the corporate sponsors of the Spondylitis Association here today. We have Angela with AbbVie, and we have Julie and Scott with UCB. And they're here, so during breaks, please feel free to say hello and welcome them. But none of this would be possible without support of people affected with spondyloarthritis, because the bulk of the support the Spondylitis Association receives is from people living with spondyloarthritis. The Spondylitis Association of America was founded by people with spondyloarthritis, and it's their friends and family who's been supporting us and driving the quest for the cure and the support to people living with spondylitis ever since, and it's been 30 years we've been here. We have several breaks built into the agenda, but as custom with Spondylitis Association of America, whenever you feel the need to stand up and stretch, feel free to do so. There's refreshments out back. I think it's coffee and sweets. Looks like fruit as well. Bathrooms, just administrative things. Bathrooms are down the hall here. Men's on the left, and my wife always says women are always right. If you could take a moment to silence your phones and tablets and other devices, that would be greatly appreciated. And we're going to start right off the bat. It's my pleasure to introduce Lori Savage. Lori Savage has been with the Spondylitis Association for nearly 20 years. Lori has been one of the most hardest working people on behalf of spondylitis in the world today. She's constantly searching for ways to improve the lives of people with spondylitis and tenaciously drives programs. Not only has she published groundbreaking research, authored articles on spondylitis, she champions the work of others. She's one of the spondylitis community's greatest assets and thought leaders. Please help me welcome to the podium our Executive Director, Lori Savage.
Good morning, everyone. Good morning. Thank you for being here. We're so excited to bring you this program, and thank you, Richard. I didn't know he was going to say all those nice things about me. So we have a terrific lineup today for you. We are here for you. That's why we exist. We are here to support you. As Richard was saying, our organization was established by a group of patients and their physicians about 32 years ago. And it started off as a cutting-edge organization, and we remain a cutting-edge organization. We try new things on your behalf, and today we're actually streaming live this program. I think we have about 300 people who are watching this program and participating remotely, so this is a very exciting thing for us. Now, the program will be archived on our website so that individuals who couldn't make it today on any level will actually have the opportunity to enjoy the program. Currently, we are supporting Dr. Jim Rosenbaum, who is conducting a cutting-edge microbiome study looking at the gut and what the triggers might be, with potentially the goal of preventing the trigger as a prophylaxis so that we can prevent people from triggering the disease and going through what many of you are going through today, and your children and your grandchildren. We are also supporting Dr. Joel Turog, who is looking at the genetic components of this disease. About 30 years ago, B27, the prime primary gene that causes susceptibility to ankylosing spondylitis was uncovered. And Dr. Turok has been working in this arena for all of that time, and he is very likely going to uncover some very important breakthroughs in the next few years that will not only help manage the disease, but also serve as prophylaxis, preventing the disease, and also be a strong component with regard to translational research, meaning new medicines that will be developed on your behalf. Now, one of the reasons that we have these types of programs is that it's very, very important for individuals affected by spondyloarthritis to be knowledgeable so that they can manage the condition. We can only go so far. A knowledgeable patient is a successful patient. And also one of the marvelous things about this program, I do believe, is that you get to meet with each other and we get to meet you. And really, the experts in the room are you. So thank you for being here. Enjoy it, enjoy each other. Spondyloarthritis is a serious condition, as you all know, but that doesn't mean that we can't have fun today. So thank you for being here.
All right, it's my pleasure to welcome Dr. David Hallegua. Dr. Hallegua is a board-certified in rheumatology and internal medicine with a private practice. He is an attending physician at Cedars-Sinai Medical Center. Dr. Hallegua is an assistant professor of medicine at Cedars-Sinai and at UCLA School of Medicine. He's also a member and former chairperson of the Spondylitis Association of America Board of Directors.
Good morning, everybody. It's my pleasure to be here and to give you an update on the treatment of ankylosing spondylitis and its multiple partners, as you see in crime. We have made great advances to put some of those people, or I should say illnesses, that cause these various maladies behind bars. We have genetics, we have great therapies. The genetics help to detect these illnesses wherever they hide, and the therapies help to put them away, hopefully for good, and not let them create the ravages that they do. If I could have the next slide. Oh, I guess I'm in control here. Okay, there we go. No, that didn't work. Now I understand what you're talking about. You can't see what you're here. Which one's the button to advance? Which is the button to? No, I'm good. Don't worry about it. Which one is the button to advance? Okay, perfect. I'm going to point to. Okay. So the spectrum of spondylitis is very wide. We are all familiar with ankylosing spondylitis, which has been traced back to ancient times. Here we see a picture of a person who's trying to bend down to touch their toes and is unable to do so because of stiffness and pain in the back. This person most likely has fusion as well. This illness requires an X-ray to diagnose. It is not ethical to go and X-ray, let's say, 5,000 people selected in the population to determine the exact frequency of sacroiliitis on the X-ray. It is not ethical to expose normal individuals to X-rays and possible X-ray exposure in order to find out what the frequency of ankylosing spondylitis is in the population. An early study in the 1970s estimated that only 0.2% of the population was affected based on using X-rays. However, more recent studies that have used more metrology measures, which are measures done to see how well people can bend, have identified AS to be present in about 0.55% of the population. You have to have the X-ray changes and a clinical criteria of inflammatory back pain, pain that's present at rest and improving with activity, or you have to have limitation in motion in one plane, either bending forward or some other form of limitation of motion, such as chest expansion, with the X-ray criteria to make the diagnosis. Oops. Axial spondyloarthritis is a much larger pool of patients. The Spondylitis Association decided that the best way to detect this large pool of patients that may go undiagnosed is to take a questionnaire to the public, and the internet was the best venue to put up this questionnaire. They spend a large amount of money developing the questionnaire with the help of researchers, and came up with a back pain questionnaire that is on the web right now that patients with back pain could take and come up with a likelihood of whether they have spondylitis or not. The patients who were studied to develop the questionnaire was ankylosing spondylitis patients. So we are not sure whether axial spondyloarthritis, which is a condition where the X-rays are negative for sacroiliitis, but MRIs have the presence of sacroiliitis with inflammation in the sacroiliac joint or somewhere else in the vertebra, is present. These people also have the inflammatory back pain present. The questionnaire that was developed by the Spondylitis Association was used by Dr. Ravel in a national survey where no X-rays were used, but questionnaires were administered to 1,000 or 2,000 people, carefully selected to represent the ethnicity and age that is representative of a national sample of people. In that enhanced survey that was done in 2011, the prevalence of axial spondyloarthritis, which probably includes ankylosing spondylitis as well, is 1.4%. 1.4% is a number that translates to about 4.5 million almost, much higher than the prevalence of rheumatoid arthritis, much higher than the prevalence of lupus, multiple sclerosis. So this is an illness that is very common. We are probably only detecting the tip of the iceberg, so to speak, and we need better methods to identify these patients. Spondylitis Association has embarked on a mission to educate radiologists and other physicians who read MRIs and X-rays so that these patients can be identified. But I believe that the key to identify these patients is to come up with a blood test that includes a combination of genes that will allow us to identify these patients at risk and patients with back pain who have this condition. I think we are on the cusp of having such a biomarker tool, and it will be available soon to detect these patients. Axial spondyloarthritis has symptoms that are just as disabling as ankylosing spondylitis, and the therapies that we have for ankylosing spondylitis work very well for axial spondyloarthritis as well. Peripheral spondyloarthritis, as the name implies, refers to a portion of the spectrum of spondyloarthritis where there is no axial or spine involvement. The involvement can be in the Achilles tendon, as you see in this picture. It can be in a joint, such as the hip or the knee. It can be in the nails only, as in psoriasis that affects the nails. It can be a sausage digit, and I will show you a picture of what a sausage digit looks like. And patients with this condition, if they have a very specific spondyloarthritis feature, such as Crohn's, such as psoriasis, with the presence of plantar fasciitis, Achilles tendonitis, then they fulfill criteria for peripheral spondyloarthritis. If Crohn's, psoriasis is not present and only, let's say, enthesitis is present, in order to be really sure that this person has peripheral spondyloarthritis, you will need to have two other features. So you would need to have arthritis and perhaps another manifestation like tendon attachment inflammation. You've probably seen various types of cartoons that gives you an idea about the spectrum of spondyloarthritis is. Usually it's overlapping circles. This cartoon gives you a different spin on it. You can see that the section that represents peripheral and axial spondyloarthritis is actually fairly big. And I believe that is what exists in the population. These conditions are not stationary, they do evolve over time. About 40% of people with axial spondyloarthritis, when followed for 5 to 7 years, will develop ankylosing spondylitis with sacroiliitis on x-rays. 20% go into remission, and about 30 to 40% remain the same. This has been replicated in multiple studies. Peripheral spondyloarthritis, on the other hand, does not evolve into AS most of the time. This is largely because the HLA-B27 gene marker is often not present in the subgroup of patients with peripheral spondyloarthritis who do not progress to AS. It is HLA-B27 and MRI evidence of inflammation in the sacroiliac joint, especially strong evidence of inflammation, that drive axial spondyloarthritis to evolve into AS. I do believe that if we detect axial spondyloarthritis early, we will be able to prevent this transition and perhaps put a lot of people into remission. However, it has been difficult to identify the subset because of the reasons I mentioned earlier. As you can see, all these conditions can be associated with Crohn's, with psoriasis. It can be associated with ulcerative colitis, reactive arthritis. So it is an amalgamation of different illnesses in various combinations, largely because of the genes that drive the illnesses to have different manifestations. So what are the symptoms that some of us in this room experience on a day-to-day basis? Pain is an important symptom, and a lot of our therapies that we have addresses that very well. Stiffness and decreased range of motion due to fusion or just pain is another important symptom. Bleeding and constipation, abdominal pain, and fistula formation, which refers to openings connecting the bowel to the surface of the skin, is seen in Crohn's disease that often accompanies ankylosing spondylitis or axial spondyloarthritis. Some studies have shown that if you do colonoscopies on patients with ankylosing spondylitis, about 50% of them have inflammation that doesn't cause symptoms. 20% of AS patients will have frank inflammation and symptoms in their gut. Rashes, nail abnormalities, and mucosal lesions can be seen with reactive arthritis and psoriasis. The iritis that accompanies ankylosing spondylitis, you'll be getting a full talk on that. I won't spend too much time on it, but 25% of AS patients have it. These symptoms like iritis could precede the diagnosis of axial spondyloarthritis or AS by many years. Other things that can be seen include osteoporosis, which affects 50% of people with ankylosing spondylitis. The prevalence of fractures is about 18%, and therapy that reduces inflammation does help to improve the bone density, and medicines approved for osteoporosis do work for patients with AS who need them as well. Untreated inflammation leads to cardiovascular disease, and therefore it is important to treat risk factors for cardiovascular disease in these conditions to control the symptoms. So how do you approach treating the manifestations? You have to take a good history in order to identify what symptoms are present. Some of them may be historical symptoms, like a past history of iritis. You have to take a history of where the person is from, because risk of tuberculosis is higher in developing countries. So a person who immigrates to the United States may have a higher risk of tuberculosis exposure when they were young and may need to be treated differently. People who live in different parts of the United States have unique exposure risks to various fungal illnesses. In our area, cocci or coccidioidomycosis, which is a type of fungal infection, a fungus that's found in the soil that can be aerosolized or put into the air when there's excavation, is known to affect people who are immunocompromised. Physical exam helps to identify the manifestations associated with illness and also to confirm the risk that I mentioned. The laboratory testing should include TB exposure, so that would be with a skin test for TB or quantiferon blood test, because the therapies that we use, like a biologic, can reactivate TB that a person has been exposed to. It is also important to check for hepatitis virus exposure in the past, since even people who have been treated for hepatitis viruses can develop reactivation even if their carrier state for hepatitis B is negative. About 5% of people can activate, and if they are a carrier, then they need prophylaxis before they are treated. Imaging includes the X-rays and the MRIs that we talked about earlier. So one important question is, why do only 5% of HLA-B27 positive patients get the disease? HLA-B27 is seen in about 7 to 8% of Caucasian people in the United States. The prevalence is a lot lower in other minorities such as the African American or the Asian population, but only 5% of the HLA-B27 positive individuals get ankylosing spondylitis or a related illness. The reason is that, well, first of all, out of the 65 subtypes that have been identified of HLA-B27, not all of them are associated with illness. 2 of them, which are not widely prevalent, are protective against the illness, and we don't see it with it. But there are other genes that the SAA has been instrumental in identifying that interact with HLA-B27 in causing disease causation. And some of these genes, I think, will play a role in identifying these patients in the general population. Other risk factors include microbiome changes that Laurie mentioned. There may be certain bacteria that predispose to ankylosing spondylitis. Laboratory animal models, such as a rat that has the human HLA-B27 gene added to it, demonstrate that if you treat with antibiotics and give them a specific type of a probiotic called Lactobacillus rhamnosus, you can actually prevent the disease from having an onset in that animal model. Smoking increases the risk for developing ankylosing spondylitis in HLA-B27 patients. Trauma has been associated with the onset of reactive arthritis and ankylosing spondylitis in patients who, and these are largely case reports, but some of the joints and the entheses like the Achilles tendon and the sacroiliac joints are areas that the body has the maximum amount of stress associated with it. There are proteins that we have in our body that can result in a predisposition to ankylosing spondylitis when present with HLA-B27. We did a study, again supported by the Spondylitis Association, which found a protein called the DKK1 protein. This protein is normally good in that it prevents bone formation and fusion, but it is bad in ankylosing spondylitis in that even though the levels are very high, fusion is not prevented, and so it appears to be dysfunctional and can be downright ugly in ankylosing spondylitis when it binds to the CMG receptor, which is actually an anthrax toxin receptor. When it binds to it, it is taken away from its original receptor, the DKK1 receptor, where it can actually bind and prevent fusion. And interestingly, the gene that codes for the CMG2 receptor is on the top, along with the other receptors out there. That gene was shown to show an increased risk for ankylosing spondylitis in the Genome-Wide Project. So what are some of the major classes of medications that we use to treat AS? NSAIDs have been used, and NSAIDs have an indication in ankylosing spondylitis. Pretty much every NSAID has been shown to be effective. COX-2 inhibitors such as celecoxib plays an important role because of its sparing of the GI tract in terms of ulcer formation, and as we discussed, 50% of AS patients have inflammation in that area. Other DMARDs include sulfasalazine, methotrexate, apremilast or Otezla. Steroid injections are particularly useful in patients who have enthesitis or peripheral arthritis, and topical steroids are useful for psoriasis. On the other table, biological agents, the major classes include receptor agents that bind TNF, and etanercept or Enbrel is the example for that. Antibodies against TNF, and infliximab, certolizumab, and two others that are listed there are examples of it. There are adhesion molecule inhibitors. There were some approved for psoriasis that have been withdrawn because of side effects. The two that we have right now is more for Crohn's disease. The bottom line refers to antibodies that bind interleukin 12 and 23. There's one that's approved and a couple more that will be approved soon. They're approved mainly in psoriasis and psoriatic arthritis at this time. And antibodies directed at IL-17 is also very promising. There's one that is approved right now for psoriasis, and approval for other illnesses will follow soon. So NSAIDs are very effective at reducing signs and symptoms, including pain and stiffness. Multiple trials have shown this. There is some evidence that NSAIDs can prevent fusion when it's taken continuously on a daily basis, preferably at bedtime. The effects of prevention of fusion are small, but there have been 2 studies that have confirmed this effect, so I believe it is real. The COX-1 blocking NSAIDs such as ibuprofen or naproxen or indomethacin or diclofenac, all of which have approval for ankylosing spondylitis, are more difficult to take on a daily basis because of their GI side effects, and major GI side effects such as a peptic ulcer with bleeding in 1% of patients who take it continuously for a long period of time. But celecoxib, which has less GI side effects, has a role in some patients who may be able to take it continuously, monitoring their blood pressure closely to prevent an increase that may be associated with cardiovascular disease. The example that I said of etanercept, which is a receptor that binds TNF, has been consistently shown in multiple studies to give what is called a composite outcome measure, reducing pain, stiffness, and disability in ankylosing spondylitis. 70% of patients achieve this composite ASAS 20 measure, about 50% achieve the ASAS 50 improvement endpoint, and about 20 to 30% achieve this ASAS 70% endpoint. The other TNF blockers, such as the monoclonal antibodies, are very similar in terms of their response for AS with respect to improving pain and stiffness and function. Etanercept is very effective in achieving a response called the PASI 75 response. This is a psoriasis outcome criteria where 75% of a rash clears up when you use this medication. Other drugs, including infliximab and Humira, also achieve this outcome, and Remicade or infliximab does better when combined with methotrexate in treating this rash. Here's a slide on the left side where you see a little inset showing you what a sausage digit looks like, and I picked up infliximab to show that this sausage digit, which does not really respond well to anti-inflammatory medications, responds well to infliximab or Remicade. The range of improvement is about 60 to 70% of sausage digits do disappear when Remicade and other TNF blockers are used to treat these conditions. On the right side is an example of a bowel affected by Crohn's disease, with clearing occurring, in this case with treatment with sertolizumab or Cimzia. One note to know is that etanercept does not control GI manifestations, and Crohn's or colitis flares can occur while you're being treated with etanercept. Here's an example on the left of adalimumab or Humira and its effects on iritis. There's been open label trials looking at past flares of iritis in the past, and going forward with Humira or adalimumab treatment, showing that 60% of patients who had chronic iritis or episodic iritis, recent iritis, 60 to 70% of these flares were prevented with the treatment of adalimumab. This is also a condition where etanercept does not perform very well, but the other TNF blockers do have good response. On the other side is golimumab or Simponi, and I have used the trial that they did in ulcerative colitis to show that it heals ulcerative colitis, which is probably the most common form of the spondyloarthritis and related illness worldwide. 4 of the 5 TNF blocking drugs are effective in preventing flares as well as reducing the severity of the illness when ulcerative colitis is treated with these agents. What about the effects of TNF blockers in preventing fusion? Well, similar to NSAIDs, trials have been looked at to see whether the TNF blockers can prevent fusion. It would not be ethical to treat a cohort of ankylosing spondylitis in a double-blind fashion where half patients get placebo for the required 2 years to clearly show the difference in fusion, because fusion is a very slow process. But investigators have been able to look at it in another way, where they have taken patients and separated them based on their risk of fusion into rapid progressors and people who do not progress very rapidly by looking at the progression between x-rays done at a minimum of 1.5 years in between the x-rays. And what has been found is that if you treat the disease for a longer period of time with TNFs, there is less fusion, whether you're a progressor or a non-progressor. If you delay the onset of treatment of the TNF blocker by 10 years or more in people who are predisposed to progression, you have a higher risk of progression to fusion. So these drugs are effective in not only relieving signs and symptoms, and as I said earlier, I believe that if we started them with people with axial spondyloarthritis before ankylosing spondylitis is apparent, we can probably prevent fusion, although that study has not been done yet. What about some of the side effects? Well, infections are common with TNF blockers. They tend to cluster early on in these illnesses when the condition is started and later tapers off. One study with rheumatoid arthritis, as you can see, shows that there is a 50% decrease in mortality in the group of patients who took TNFs as opposed to the patients who did not take TNF, and probably because of protection from inflammation causing cardiovascular events accounts for that decrease in mortality. So even though infections do occur, as long as you identify patients carefully, you identify whether they are predisposed to tuberculosis and take INH prophylaxis for a minimum of 3 weeks prior to starting the TNF, you can prevent that. If you are a carrier for hepatitis B surface antigen, or you have been exposed to hepatitis B in the past, and you can take prophylaxis for it and prevent the activation of hepatitis B in patients. Patients are predisposed to various bacterial infections. A few of them are listed up there with possible preventive strategies for both TB, bacterial infections, fungal infections, etc. One would expect shingles to be increased in patients who are receiving treatment with TNF blockers, but although the incidence is high, the incidence of shingles or herpes zoster is not elevated with TNF blocker use. The second time getting shingles again because you have not been, it hasn't been shown to increase incidence, the chance of a second infection is very high in a person who has shingles to begin with. So I don't think we know from data that using a TNF will cause an increase in second time. There is the shingles vaccine, but it has not been studied with sufficient amount of safety to be used in patients with autoimmune illnesses. Yes, Helen.
Is a non-live shingles vaccine being worked on?
I'm not aware of one. The vaccines for chickenpox and shingles are live, I think. Other adverse events depend on, the presence of comorbid conditions. Congestive heart failure, if present, should give caution in starting these medications, since mortality was increased when patients with congestive heart failure who have high levels of TNF were given TNF to see if it could improve congestive heart failure. Patients who have predisposition or who have multiple sclerosis should not be given these drugs, because plaques increase when anti-TNFs were used in trials to see if multiple sclerosis could be improved. Low blood counts can occur. Lupus-like illnesses have been reported. It's rare, and screening with an anti-nuclear antibody may be useful to identify patients who might be at risk for it. There is a higher risk of lymphoma, a twofold increase, and skin cancer. You can identify patients who are at risk for skin cancer based on their exposure to sunlight and their past history of skin cancer. It's generally easy to detect and should not prevent the use of a TNF blocker if it is non-melanoma skin cancer. Any other cancer that occurs warrants a period of 5 years of observance before you start the therapy, except in very exceptional circumstances. Psoriasis rashes can occur de novo in anti-TNF therapy. Usually this happens, 70% of it happens in the first year, but it can happen later. This is, it's unclear why it happens. It may be that the TNF blocker actually binds to certain cells, to TNF bound to the surface of the cells, and actually activates some of those cells to be pro-inflammatory in the initial period, and that may result in a psoriasis rash occurring, for example, in the first year of treatment with etanercept. And if you were to stop the etanercept and switch it to a different drug, such as adalimumab or Humira, you would see that the rash would go away. Sometimes the rash is mild enough where you can even continue therapy. The infusion reactions is often seen with Remicade, which has a foreign mouse protein on it. Injection site reactions are common, but often not severe enough to stop therapy with the injectable TNF blockers. These are the examples of the non-biologics that we use. They are effective more for peripheral spondyloarthritis. Sulfasalazine is the mainstay and often used as the initial drug before we embark on treatment with the TNF blocker. Methotrexate has also been used with some success. These drugs are not effective for axial disease or spine pain. Thalidomide has been used, but blood clots that occur with thalidomide and side effects of drowsiness reduces the use of this drug. Leflunomide has been used in a pilot study as well. Pamidronate is not used very often. It's an intravenous drug used for the treatment of osteoporosis. A pilot study done by Dr. Maximovich in Canada showed a positive response. Very few side effects of maybe some flu-like symptoms were seen, but it is not used very commonly. Apremilast or Otezla is a new drug. It's an oral drug. It has been approved for psoriasis and psoriatic arthritis. it is effective in those conditions in giving you positive ACR scores in terms of the arthritis, as well as positive reduction in the skin score. It has been tried with ankylosing spondylitis. It failed to reach its endpoint, even though some patients did have a response with improvement of their ASAS 20 scores, and individual things such as stiffness and pain did improve in a lot of patients, but it did not meet the outcomes that were predicted. These are some of the side effects of these medications, the non-biologic agents. They are bothersome, troublesome. They tend to be more intrusive into one's daily life than the side effects that are seen with TNF blockers. Except for peripheral spondyloarthritis, they are of limited use. These are the adhesion molecule blockers that I spoke to you about. These are indicated for Crohn's disease, and how they work is that the adhesion molecule blockers tend to, tend to prevent the cells that are in the circulation from squeezing outward into areas of inflammation by blocking the cell surface receptors that bind to various cell adhesion molecules on the surface. Tysabri is one of them. The other one that was recently approved is Entbio. The adhesion molecule blockers are limited in our spectrum, except for people with perhaps Crohn's disease and peripheral arthritis, which responds when you control the inflammation in the bowel. The spinal arthritis does not seem to respond as well when you control the inflammation in the bowel. These conditions have some unique risks. These drugs do have some unique risks that I will talk about. Ustekinumab or Stelara is an IL-12, IL-23 blocker. It's a mediator of inflammation. This drug blocks a subunit of that. There seems to be efficacy not only in psoriasis and psoriatic arthritis, where it has received approval. It is also promising in Crohn's disease as well as ankylosing spondylitis. There was a drug that was in development from Abbott, I believe, that was an IL-12, IL-23 blocker that was withdrawn during phase 3 development stage because of some cardiovascular side effects. That study was done in psoriasis, where there is a high cardiovascular risk profile because of sometimes weight gain and metabolic syndrome changes. So far with this drug, we have not seen an adverse cardiovascular risk profile, but I would caution that when it's widely available for various indications, including AS, that if cardiovascular risk factors are present, such as hypertension, diabetes, high cholesterol, family history, that those risk factors be addressed before people take the IL-12, IL-23 blocker. IL-17 blockade is very promising in ankylosing spondylitis as well. Currently approved for psoriasis, psoriatic arthritis is likely to follow very soon. I think there are a number of IL-17 blockers that are in development. Studies in ankylosing spondylitis shows very promising results as well. This drug was just recently approved in January for psoriasis. So, side effects of these agents. The adhesion molecule blockers have a unique side effect in that they can lead to a virus reactivation within the central nervous system that can lead to a neurological illness called progressive multifocal leukoencephalopathy, or PML. This is a serious illness that is often fatal, and you can avoid it by limiting the course of therapy to less than 24 months in patients who test antibody positive in the blood for JC virus exposure. If you're antibody negative, then you could continue to take the drug beyond 24 months. The new drug that's been approved carries that warning as well, but we have not seen too many cases of PML with this. The interleukin 12-23 is generally well tolerated. Rare skin cancers have been noted. Rare cases of something called reversible posterior encephalopathy syndrome. One case has been reported. It's usually seen with hypertension and sometimes as side effects to other drugs as well, where people get confused transiently. There's swelling in the posterior part of the brain, and most people recover with it with withdrawal of the drug. It's rare with it. The cardiovascular side effect is, I think, a little bit more important to pay attention to, and as I said, appropriate steps should be taken to prevent it. Anti-interleukin 17 therapy, besides the usual precautions of TB testing to make sure there's no exposure to TB, it seems to be fairly safe. It does not control bowel inflammation, and therefore we need to avoid it in patients who have significant inflammation in the bowel, because that will not be controlled with this group of drugs. So what is the future for this? As I said, there are a few IL-17 blockers that are coming our way. The first two on that side, the ixekizumab and brodalumab, are two agents that are in phase 3 trial that will probably be approved for psoriasis this year. Briakinumab was withdrawn by Abbott in 2011 because of the cardiovascular events, most likely, though we do not know the answer. They were studying it in Crohn's too, but the results were not promising. So I do not think that we will see this drug in the future, though I'm not sure whether there are any open label long-term trials in progress to see if the drug is indeed safe in patients who do not have a lot of risk factors for cardiovascular disease. The HLA-B27 homodimer, I will wait till the next slide to talk more about it. It is probably at an early stage and it may be promising. Microbiome alteration I spoke about. It's also in its early stage, mainly shown in laboratory animal models such as the transgenic HLA-B27 rat to be protected if you give antibiotics and then give the Lactobacillus rhamnosus GG subtype of probiotic, can prevent the development of the illness. But if you give the probiotic alone to these rats, it does not protect, and you have to give the antibiotic and then the probiotic. Whether that will show promise in the future is to be seen. I do believe that we're a little bit more complicated than the rat, and the world is a little bit more complicated than the laboratory environment that the rat is raised in. But I hope that this will show promise. Gene interference I will talk about in the next slide as well. I believe this is the last slide. The cartoon on the left side shows how an HLA-B27 molecule is processed in the cell and expressed on the cell surface. So the HLA-B27 molecule is translated in the nucleus. It comes to the surface, and as you can see, it's folded, and there's a smaller molecule which is a beta-2 microglobulin protein that enables this folding to occur, and then it binds the antigen on the surface. The HLA-B27 can sometimes ignore beta-2 microglobulin and form these homodimers, which means it has this 3-protein HLA-B27 molecule that combines with another HLA-B27 molecule and expresses itself on the surface. This complicated way of this protein being expressed on the surface, if anything can go wrong in the body, it often goes wrong. And it can misfold. And this misfolding in the body can lead to stress within the endoplasmic reticulum where these proteins are processed, and it can lead to an inflammatory response where cells called natural killer cells, they detect misfolded HLA-B27 homodimers that float in the circulation, and that leads to an immune response called Th17 immune response, which generates the interleukin 17 that I spoke about, where we have new blockers that will help to control the illness. So there is promise if you can block the HLA-B27 homodimers that are in the circulation, that you can prevent this natural killer cell activation, which can help to reduce inflammation without an anti-TNF, perhaps in a subgroup of patients with ankylosing spondylitis. Very early stages, we don't know what it will be promising. Here's another cartoon showing that ERAP gene, which stands for an endoplasmic reticulum aminopeptidase gene, that it's shown in multiple trials to be a gene that carries risk for an individual who has certain subtypes of this gene to be predisposed to ankylosing spondylitis when it's present with HLA-B27. This combination is possibly going to help us detect patients. What this gene does is it produces a protein, which is an enzyme that works in the endoplasmic reticulum, splicing HLA-B27 and making that gene expressed on the cell surface longer, smaller, different. The capability to bind antigen is changed by these subtypes of the ERAP gene present. So there is a biological basis for strong interaction between these two genes that can predispose to disease predisposition as well as severity. Some subtypes are being identified and being worked on in both the rat model that Lori had alluded to, and I think this might be promising in terms of therapy as well, with RNA molecules that can interfere with the ERAP gene product activity within the endoplasmic reticulum. I want to thank the Spondylitis Association. I want to thank Lori, Richard, Ellen, and everybody on the staff for inviting me to talk to you. I'm glad my neck was able to move and look at the slides. It would have been challenging for me if I had pain in my neck. And I thank the Spondylitis Association for everything they do, and they will strive until a cure has been found for this illness. Thank you very much.
Do you have time to go over? No, we're fine. Okay, we're good. We're really good. We're going to take questions and answers. So there's two microphones set up. It's best if you can come up to the microphone and ask your question, either one. And if you're not walking around today, just raise your hand and we'll bring you a mic. So questions and answers. Thank you.
Sure.
If you have had a melanoma in the past, what kind of drug treatment would you recommend?
Say that again one more time.
If I've had melanoma,
Ah.
so what kind of drug treatment would be best?
First of all, it's the timing as to when you suffered this illness. Assuming it's more than 5 years, the next question would be, what is the spectrum of illness that you have that will enable us to choose a treatment that will fit your disease spectrum, so to speak. So I have 50% of my AS patients only take an anti-inflammatory. It works very well for them. My patients who only have peripheral spondyloarthritis, wherein the NSAIDs are not effective, may take a non-biologic disease-modifying drug such as sulfasalazine or methotrexate and do well. I think if the duration of times that has elapsed from the melanoma diagnosis is more than 5 years, I would not hesitate to choose a biologic to treat the condition if the spectrum of illness warrants it. Do I have a preference of a biologic? I do not have good scientific basis. Well, I take that back. I do have some scientific basis to make this, but I don't think there's any published information to warrant the choice of the biologic. But I would prefer to use a receptor that binds TNF rather than a monoclonal antibody, only because receptors that bind TNF do not fix a protein in the blood called complement. Fixing complement is a property of antibodies that bind TNF, and when you fix complement, you lyse cells. You destroy the cells that may play a role in protecting you against a cancer. So maybe etanercept is a little bit safer. I am not sure whether IL-17 blockers will fall into that same class with the etanercept. In my mind, it is really too soon to tell.
Is it possible for a relative, I have AS, and is it possible for a family member who does not test positive for HLA-B27 to form AS in their bodies?
Yes.
It is.
It is possible because when you take clinical trials and epidemiological studies, only about 60 to 90% of people are HLA-B27 positive, depending on the type of patients that you're studying. So if you're studying exclusively patients who have spinal involvement, fusion, and the AS phenotype or appearance, it is likely that you will see 90% positivity. On the other hand, if you look at the axial spondyloarthritis group, a large group, that perhaps has inflammatory back pain with a little Crohn's disease, the HLA-B27 frequency in that group of 100 patients may be only 30-40%. But if your question is AS specific, yes, it is possible. More likely in non-Caucasian patients, less likely in Caucasian. The absence of an HLA-B27 in a family where everybody with severe AS is HLA-B27 positive, and somebody, sibling or a child who's HLA-B27 negative, I think will have a much, much lower risk.
What about the, excuse me, what about the testing of grandchildren? I have young grandchildren. Is there any reason to subject them to any kind of testing?
I would not test unless there are symptoms until we have a preventive therapy, and maybe we will with the laboratory experiments with the microbiome that we are doing. I would also not test them until we have conclusive combinations of genes that really give you risk rather than HLA-B27 alone. The risk of disease in an affected sibling, in an unaffected sibling or in children of a patient with ankylosing spondylitis ranges between 5 and 20%. So it's not absolute, and I would not do it until we have effective screening techniques as well as preventive strategies. Hello.
Thank you for your wonderful talk.
Thank you.
I have two somewhat related questions. And the first, and I'm going to sit down so I can write down your answers. The first is specifically which bacteria are seen to be triggers in the animal models? And number two, would you say it would be prudent for people with AS to start taking the protective probiotic, and what exactly is the name of that?
Loaded question. I'll wait for you to sit down. So there's been a lot of literature in the past looking at Klebsiella, which is a common bacteria that I would think that 99 or 100% of us in this room have, and in a neighboring room with a different conference unrelated to AS, probably 99 to 100% of them will have Klebsiella as well. However, Klebsiella subtypes have been thought to play a role. It has been very difficult because of almost the universal presence of Klebsiella to tie this bacteria down to AS predisposition. So that has been shelved. There are about 1,000 species of bacteria, different kinds of bacteria in all of us, in our gut. And the ratio of bacteria to human cells is somewhere around 100 to 1 or 1,000 to 1, depending on how much bacterial overgrowth we may have in our gut. I do believe that bacteria do play a role when animals are grown in a germ-free environment, when they have the predisposition to lupus, ankylosing spondylitis, rheumatoid arthritis. They do not get the disease. When you introduce the bacteria, the interaction between the bacteria and the genetic makeup of the animal brings on the disease. As I said earlier, the experiments done by Dr. Torog and his colleagues, he developed this rat that's transgenic for HLA-V27. It's not a gene that the rat normally carries. It is a somewhat abnormal rat in the sense that we carry one copy of HLA-V27 per cell, two genes that express HLA-V27. This poor rat has been given anywhere from 30 to 50 copies of HLA-V27 per cell in the body. So, it's primed to get spondylitis, so to speak. But nevertheless, the rat gets it, and it's a form of spondylitis that resembles to a great extent what humans get. And when they treat with antibiotics and do nothing, and the germs come in, the disease happens. When they treat with antibiotics and they give different forms of antibiotics, different forms of probiotics, the disease is prevented to a large extent, not completely. Sometimes the disease is just, ameliorated and it's less severe. Sometimes it's completely prevented. So the bacteria that appeared to protect the rats, and none of us in the room, fall into that category. So, we can't really apply it to AS patients just yet. But it's commonly available over-the-counter probiotic called Lactobacillus rhamnosus, and rhamnosus is spelled RHAMNOSUS, and there's a GG subtype of this Lactobacillus rhamnosus that was used in the experiments, which showed that it protected. Other types of lactobacilli or probiotics did not protect. Some species of lactobacilli actually made things worse. In terms of the other part of the question, are there other bacteria that may predispose to AS, at least in the rat population? I cannot tell you those because I think not all of it has been published by Dr. James Rosenbaum, who's doing some of this research, and I'm not privy to disclose any information yet. Again, it's in the animal model. We do not know whether it'll translate to the human population. Oh, sure, okay. Good point. Come on. You can give part of the answer. So, Laurie, who knows a little bit more than me, rightfully pointed out that I should mention about reactive arthritis, which was on the screen several times and is a condition, as a lot of you may know, is triggered by chlamydia or Salmonella Shigella infection. Chlamydia affecting the urogenital tract and Salmonella and Shigella affecting the bowel. So those bacteria in people who have HLA-B27 positivity, possibly the ERAP1 positivity, will create arthritis that is either peripheral or central, depending on their genetic makeup, in a lot of patients. And reactive arthritis refers to the triad of symptoms of conjunctivitis, arthritis of the large joints of the body, as well as urethritis. And it was used to be known as Reiter syndrome. We don't call it that anymore because that refers to one of the doctors who worked with the Hitler regime and described it, but there are other people who also described it, and we call it reactive arthritis right now. So there's you have an experiment in humans, in nature, so to speak, that shows that bacteria in the bacterial infection in the gut and the mucosa can trigger AS-like illness and peripheral arthritis in people with the right genetic predisposition. Thank you, Laurie. Thank you. Any other questions? Yes.
Doctor, thanks for being here again. Would you recommend prophylactically stop taking the TNF inhibitor if there's viruses or bacterial infections going around the home or office?
So the question is, would you stop the TNF inhibitors if there's an infection in the house? So to speak?
Or office, right.
Or office. I do not think it is necessary to do that. However, if you are nervous about exposure in a certain situation, let's say you're flying on the plane in the middle of flu season and you're going to be sitting with 200 people, half of them are coughing. I think the more effective strategy than stopping the TNF would be to take a specific drug that can prophylax against that particular organism. So taking Tamiflu once a day for 5 days is effective prophylaxis against the flu and would be much better and more protective against getting the flu in somebody whose immune system is really compromised on a TNF inhibitor or years of steroid use for AS or other conditions such as Crohn's disease. That would be better prophylaxis than stopping the TNF inhibitor, which may result in a flare when you get to your destination, which would make your trip miserable. So,
What about bacterial? Because Tamiflu is viral, right? So if there's bronchitis going around my office right now, this is why I'm asking.
I will write a note for you to take some time off.
Thank you very much. This was so worth coming here.
No, I mean, sorry, I didn't mean to make it a joke, but bacterial infections are preventable too with prophylaxis. Some infectious disease doctors give daily Zithromax or Biaxin treatment to patients who are predisposed to repeated upper respiratory tract infections. I have a psoriatic arthritis patient on Enbrel who takes Biaxin every day. And, she's done it for 10 years, partly because she wants to do it. And I've given her my permission with an ID doctor's recommendation to continue it. So many types of prophylactic treatments are available, including rifaximin for travel. If you're worried about traveler's diarrhea, you could take that if you're on a TNF blocker and traveling abroad, but you may not be immune to the bacteria in the water and so on.
I have AS, and I have had and I have a history of associated diseases with it. I would like to know, in your experience, because of the time that you have done research and you are a physician, it's kind of like on the chicken and the egg, which came first. I'd like to know what your experience is on people with all of that combination. Did you find that the associated diseases might have led you to think they might have AS if they had not been diagnosed or marked for the gene? Or did you, or do you then observe and take precautions for people who have AS and what goes down the way for the associated diseases? I'm always curious as to which came first, or not at all.
Okay. Well, thank you for the question. So as I put in that slide that shows the spectrum of spondyloarthritis, the possible variations and combinations as to how these conditions manifest themselves initially and what follows is probably as diverse as the combinations on a safe, that you're trying to break into. People can present with a sausage digit and have nothing else for 10 years, and then they get colitis at the end of it. I have a physician colleague who has ankylosing spondylitis from a very young age and had every manifestation of AS. His father had nothing till he was 90 and then comes down with bilateral iritis. That's typical of AS-associated iritis. Why at 90? Why nothing before that? Was there something subclinical all along? So, my belief is that if you dig deep, no pun intended, that you will find subclinical inflammation in the skin, in the mucosal tissue, in the gut, and within immune cells in all patients with spondyloarthritis. Whether that crosses that subclinical level and becomes overt depends on perhaps our microbiome, perhaps external factors such as trauma to certain tendon attachments, maybe triggers such as the Salmonella, Shigella, or Chlamydia, or the type of genetic makeup that we as individuals are all different. And we can all have HLA-B27 in the room, but there are different subtypes of it. A segment of our HLA-B27 positive individuals in the room may have the ERAP1 gene, but there are different polymorphisms of those genes that result in how HLA-B27 itself is processed and put on the surface, and how antigens or proteins are processed and put on top of the cell with HLA-B27 to interact with immune cells. Very difficult to answer, but I think we will find that most of AS and other illnesses are driven through antigen exposure through the GI and other mucosal surfaces and the skin surfaces and the immune system in the future. I think that's where it starts. That's my assumption.
I have one really fast question, maybe not so fast. I'm sure we have all got diet advice here. I have cut out grains and dairy from my diet, and I think it helps, but I'd like to know what kind of diet advice you give to your patients.
Okay. I hear this every time in the clinic with new patients, established patients, that they want to know what kind of diet a AS patient should use, or psoriatic arthritis, or Crohn's patient, and they can be slightly different based on whether you have inflammatory bowel disease or not. Most people who have active inflammatory bowel disease need to have a low residue diet, meaning a diet that doesn't have a lot of fiber in it, which is generally good and healthy, but it has been implicated in causing a lot of discomfort in people with inflammatory bowel disease. Besides, so patients with inflammatory bowel disease may have a lot of starches and other things that we may also hear the media and complementary providers say that you should stay away from. And it is unclear what the relationship between gluten-containing things, sugar perhaps, or dairy, and inflammation in the body is like. I think the take-home message is that those substances that we talked about, sugar, gluten, and dairy, feed the bacteria in our gut. I think that people who have a diet rich in these will have more bacteria in their gut, and there is a constant bacterial interaction that is normal and healthy between the immune system at the end of the small intestine and the cecum, the first part of the large intestine, wherein the immune system is trying to educate itself as to what bacteria are there so they can be ready if there's trauma and bacteria gets into the body, that it's ready to respond. And taking less of those things will, I think, decrease the population of bacteria in your gut and cause less immune bacterial interaction and make people feel better from that, as well as less bloated, which translates to feeling better and lighter and being able to get around easier. And these agents do cause weight gain, and people who lose weight also generally feel better. So all around, I think it is pretty healthy to avoid those things, but it's not enough. For people with severe illness, it's not enough. For mild illness, that may be all that's needed, to be less symptomatic. Yes.
I've heard a lot of coughing. I'm 80 years old. I've been diagnosed with AS for the past year and a half. I'm on methotrexate, and I also take naproxen or Aleve. And because of swelling, my doctor put me on prednisone. I had lost my sense of taste and smell prior to that, and with the prednisone, I got it back. And it was a big miracle for me because my wife's a great cook, and I love to I love to enjoy her when I'm in the other room, just having that come through. I thought it was gone forever. But my doctor told me about a year and a half ago that he thought I had AS. Now, from hearing you talk and from reading about AS, I have made spurs, and I thought that was a good thing for the longest period of time, but I see that's also an indicator for AS. And I wonder, I've heard coughing around the room. So I wonder if that's a common with either one of these meds, or if there's something else or whatever. It's non-productive, and prednisone is also diagnosed by my ENT in a very low dosage for sinus polyps. He's done surgery once, and he said it'll come back.
Yes.
So what do you think about the two meds, prednisone and methotrexate?
As I said earlier, methotrexate is very valuable in patients who have peripheral spondyloarthritis. It is less useful in people with typical ankylosing spondylitis. Naproxen can be used in patients with ankylosing spondylitis with good results, and about 50% of my patients with AS will gain control of the AS with naproxen alone. It is not very common to give prednisone for ankylosing spondylitis as opposed to rheumatoid arthritis or lupus, but it can be done. The osteoporosis that is widely prevalent in 50% or more of patients with AS can be worsened with prednisone, and therefore you have to watch your bone density and take precautions to prevent worsening of the bone density if you are going to take prednisone for a longer period of time. I think the benefit of prednisone with your individual case in terms of improving the smell and perhaps, I don't know whether it improved the cough as well, probably has to do with the polyp condition that you have in the nasal mucosa, which also is seen when you have nasal allergies and that predispose to polyp formation. That prednisone probably addressed that and helped to restore the smell by reducing inflammation in the nasal mucosa. It can address cough too, that often exists with a postnasal drip due to allergic rhinitis or nasal polyposis. The lung involvement in AS is rare. It usually is a late manifestation, occurs after 10, 20 years of illness, and it's not very severe, but there can be some fibrosis in the upper parts of the lung, and that can be associated with a cough, but it's not a life-threatening lung fibrosis that can be seen in rheumatoid arthritis or in scleroderma or other conditions. So the other factor that a lot of people are coughing is because of spring and pollen in the air, and that allergic rhinitis is so common. My pleasure.
Good morning.
Morning.
First of all, I'm afraid I don't speak English very well, but I'm going to try to ask you something. I have AS. I taken Humira for a long time ago. I'm feeling great. But I would like to know if I can take any complement for joints like glucosamine.
Glucosamine and sulfasalazine has not been studied very well in ankylosing spondylitis. The glucosamine and chondroitin sulfate initially was recommended for pain associated with osteoarthritis, with the promise for some time that it would help the cartilage to be restored. There have been trials where the trials were done with proper attention to joint position, making sure that the x-rays done before the use of glucosamine and 6 months, 1 year, 2 years after the use of glucosamine were exactly the same, so that joint space could be measured in osteoarthritis patients. And trials, when they were done very carefully, showed that glucosamine and chondroitin sulfate do not protect against cartilage loss in osteoarthritis patients. However, glucosamine and chondroitin sulfate has been shown in multiple studies in osteoarthritis to relieve joint pain. So whether that does by fact that it's a protein and it goes in and releases something from the central nervous system, as a lot of proteins do, like growth hormone or other things that might help with some repair or analgesic mechanisms, or there's a separate analgesic mechanism with it, is unclear. But double-blind trials show that glucosamine and chondroitin is superior to placebo with pain control. But in terms of cartilage sparing, it is not being shown to be helpful. One trial, which was not done with proper joint positioning, showed a benefit, but other studies with proper joint position for x-rays showed no benefit on the cartilage. Inflammatory illnesses probably will not respond to glucosamine and chondroitin. Other supplements that have some anti-inflammatory effects, such as turmeric, fish oil, bromelain, flaxseed oil, etc., may have some benefit in a lot of patients with milder forms of ankylosing spondylitis or peripheral spondyloarthritis will take those agents and not use the anti-inflammatory agents, even though there's no data with those agents that they will prevent the progression of fusion in patients with milder illness that might be predisposed to fusion in the future.
Now, I was diagnosed in 2008, and before that, I had back surgery back when I was 17, I was using, it was fairly fast paced. I started off the Enbrel and methotrexate, and after the first 3 years, I had pneumonia 6 times. And then I got switched to Humira, and I went straight into the hospital again. I've been hospitalized 3 times, each time for 10 plus days. The first one time they thought I had swine flu, the next time they thought I had tuberculosis. So, I mean, I went into the hospital with 80 or 50 blood pressure from, in 6 hours I dropped. So I'm on nothing now. I'm on prednisone, but they're at a loss to try to figure out, they're saying it's not AS, and it's not all AS, and that's what I'm trying to get with this. They're giving the prednisone, but that really going to help much with everything else.
Prednisone has not been shown to be disease modifying in ankylosing spondylitis. It's questionable. There are some studies that show that it may have some disease modifying effects on rheumatoid arthritis, but even that's not well established. And you have a complicated history of having repeated infections. Some of the information that I talked about for prophylaxis may apply, and it may enable you to take a TNF blocker. But for example, it would mean taking Tamiflu every day plus the flu shot during the flu season to prevent flu, and it would require careful attention to hand washing and staying away from people who might carry infections.
My 8-year-old, my 13-year-old.
They need to be locked up.
I was in quarantine for 6 weeks after the last time I was in the hospital. I had to wear a mask and I couldn't go outside.
Yeah. Whether the other agents that are coming out for AS that are approved for psoriasis play a better role in terms of prevention of these common bacterial and viral infections, we have to wait and see. The oral agent, Apremilast, even though it's not approved for AS yet, may play a role. It is not a TNF blocker. It is not an interleukin-17 blocker. It's not an IL-12/23 blocker. It's a phosphodiesterase inhibitor. By virtue of its structure, it works within immune cells to reduce immune activity and has not been associated with an increased risk of infection like the TNF blockers are when they have used it in trials with psoriasis and psoriatic arthritis. And we don't have any data on progression prevention, etc., but it does address central symptoms much better than sulfasalazine and methotrexate do. So that might be an option for central symptoms of pain and stiffness in people who cannot tolerate.
Those things again, I mean,
Yeah, I hear you.